I would like to start by thanking the organizing committee for this invitation. It's a real honor for me to be here today. So my task today, I was asked to present to you what is the current science and forward thinking to reduce complications in aesthetic cases. And this is a very interesting arena because I like to look at complications in the way that we can learn from what we did in order to achieve a good aesthetic outcome. It is very important to learn from what went wrong, but I will share with you this morning a perspective of learning from what went right. I think this is the key message of this presentation. I would like to accomplish that by following this sequence, and I'm going to define briefly success criteria. I'm going to show you how we think the scientific data could be applied clinically, and I promise I have only a couple of graphics in my presentation. And then at the very end, I will share with you a practical way of measuring your own aesthetic outcomes in your practice. You know, self-assessment is something that nowadays we value in presenting these cases. And of course, I will do the final remarks, as you can see in the graphic. So, if we want to be successful, we need to understand success. And I show you a case here that certainly we were successful here. We had a fracture of a lateral incisor. We replaced it for an implant, and you see on the picture on your right, the final prosthesis delivered. Then, I'm happy to show you here, this is 1 year follow-up. Everything seems to be or stayed in the same situations, and patient is happy, and we maintain the levels, the prosthesis is still intact and functioning, and pretty much we have covered all the aspects of the success criteria. And you can see the same case at 3 years follow-up. Now, the first reflection I make here, this could be my only nice case I'm showing to you, right? And this is exactly what I would like to open the discussion is how successfully we can be in terms of reproducing the same outcome and providing long-lasting results. And this is very important for me because I will show you now a series of cases that I consider success, and you will see the difference in the outcome as well. Now, on the contrary, this is a patient that came to me to replace that amalgam for an onlay, and she had an implant bridge work done in the anterior maxilla. I want to show you now the picture, right? And what you can read on the bottom of the screen, this is what the patient told me. I'm very satisfied with my bridge. Now you can see, where do we draw the line? Because this is a case where implants are fully integrated, the prosthesis is functioning, and the patient is happy. So, of course, this range is a little bit wide. I think we could have done something different in this case, but I would like to use this case as a marking the two extremes of what we can say is acceptable or not. Obviously, in my clinic, I think this outcome wouldn't fall under that category. And there you can see some other underlying problems like adjacent implants too close to each other, probably too big, and so on. So the definition of success is very wide. That's why I asked a group of my residents, and I said, why don't we look in the literature what our colleagues are using to define success? And we published this systematic review in the Journal of Dental Research, which I called the editor and I said, I think we have a good paper. And I said, well, we only publish a systematic review by invitations, but why don't you send me the text? So we sent the text, it was published within a month, and within 6 months was the most downloaded paper of JDR for 1 year. So I went back and I read the paper and I said, what did we write here that is so interesting? And you will see that. So basically, we look at the number of criteria used to assess a success. Implant-related criteria, number 1. Number 2, peri-implant soft tissue-related criteria. And number 3, prosthodontic parameters. And number 4, patient-centered outcome. How much the patient agrees with the restoration. And you can see the success rate varies a little bit. And the first thing that is important is that if you measure success with 1 or 2 parameters only, which is most of the literature out there is what they're doing, you will be close to 100%. If you use all these 4 parameters, you will be close to 80 or 75%. So that was, I think, what made this paper really interesting. And now when I show you the next graphic, we look at how many of these parameters this article published, and you can see here, implant level, peri-implant soft tissue, a significant amount. But as a prosthodontist, I am shocked that at the prosthodontic level, 25%, 33%, 29%, and 21% of all the papers included assessed at least 1 prosthodontic parameter. So that means that if we don't assess the prosthodontic parameters in our criteria, I can place an implant in between the central and lateral incisor and still be successful, right? And you know that it's not. So I think if you take this into this consideration today, I can briefly say that if you want to assess your success, you need to consider the implant, the peri-implant soft tissue, the prosthodontic outcome, and the patient satisfaction all as a whole, as a one group. And this is exactly what this paper says. So how do we do that? So let's move on here. So the first thing is the implant position. And I want to use this graphic here because it's very interesting. The implant position determines pretty much everything that's going to happen in the treatment of that implant case in association with the maintenance and stability of the peri-implant soft tissue. So here we're placing an implant. We are doing our implant position here. And you can see I show you a cross-section. We even brought an abutment in. And now we can pre-visualize the implant position, the relationship of that prosthetic component with the planned prosthesis. Now, in this particular case, our resident planned the implant is 4.5 millimeters away from the sanity. I think it's excessively too much. So we went back, we corrected that, and we can have now a perfect implant-prosthesis relationship. So this is a great advantage when I think we probably did our first case with the bone mapping, right? Like sectioning the models and doing all that. And this is an impressive technology that we can count on. Of course, now when the implant position is finalized, we can use that surgical guide to reproduce that position into the oral cavity. And you will see here, this is exactly what we did. This is our planning. So you can see a perfect relationship between anatomy, implant position, transition or running zone, and the planned prosthesis. Everything in one screenshot. And this is also makes communication a lot easier. So I'm going to move this on a little bit. And you see here, we are now drilling for the implant placement. And now we have the site prepared. Now the movie stopped. Here you go. Now the implant comes into position. Now this is a guided mounting device that is guiding the implant into the right position. And then when you're done with that implant placement, you will need to pay attention on this side of the screen now. I'm going to show you the post-op. You see, this is how we concluded the case. This is the planning, and you will see a superimposition now of the achieved position of the implant. I know you were not paying attention, so I'm going to do it again. Right? So you need to look here. Okay? Ready? Here we go. And this you can use any implant type, brand, or anything that you're accustomed to. With I'm saying here that you have now the possibility of planning and reproduce the exact position of the implants. As a matter of fact, we have measured that in a large number of patients. And you can see here that this data comes from 28 patients and 91 implants placed in the same position. And we have a deviation at the entrance, and this is the entry point, of less than 10 microns. This is 0.008 millimeters and a 0.38 at the apical portion. I mean, this is quite accurate, and to the point that we thought that we need to redefine accuracy on guided placement, because it doesn't really matter if you are 0.20 millimeters away than you plan. What really matters is that if you plan for a screw retain with bone grafting and the implant in that position, that's what you get at the end. So, but this system is, all these systems, they seem to have a certain degree of accuracy that can improve the results. Then you can go on and, for example, here, think of more. We are planning a virtual wax-up. So you can see here, we're going to make that wax-up virtually before treating the patient. Then we're going to bring that wax-up into the 3D planning. And we can also include here a superimposition of a digital impression we took into the patient's mouth. So you can have everything virtually now in the oral cavity, soft tissue, bone, and the plant prosthesis, right? And more importantly, you can communicate with your surgical team and your prosthodontic team and the lab technicians if this is where you want to go. So the possibilities are out there. And I honestly want to say that we would like to stop receiving these cases with implant placed in a non-prosthodontic position, right? Today, there's no reason for that to happen. And in my opinion, oftentimes, the problem is lack of planning or poor executing of the cases. So I think that we have a great help here. So the surrounding tissues are very important, and this is probably the most controversial part of my topic, but this is what I do, and this is the way I think I could achieve success. You see, this study, we measure the remodeling of the bone around immediately placed implants, and this is a long study. We have all the intrasurgical measurements. Then we record the patients, a 7-year follow-up, and this is a collaboration with a group of Zurich that we did at Harvard. And then we take a cone beam CT of these patients, a 7-year follow-up, and we realize for a certain number of factors that probably will take a whole day to explain, but that 36% of those immediately placed implants, they did not have a radiographically detected bone when you take a cone beam CT. And this is particularly true for the anterior maxilla. Obviously, this implant was placed, in my opinion, too far to the buccal, and that's the problem there. And I'm sure Stephen will explain a little bit later on how to do this properly without having these problems. I'm just showing you what we sent here. And in those cases that did not have the radiographically detected bone, we had a 1.5 millimeter recession in those cases. And now if you tell the patient here, 1.2, 1.5, it doesn't really matter. Well, I think that it does in certain cases. And this is the recession of the soft tissue. But I want you to look at one of these cases that went wrong. This is a young lady here. You can see here, this is the 1.2 recession that you see clinically. But if you look at the configuration of this peri-implant soft tissue, underneath this area here, there's no bone. This is just periosteum being attached to the implant or soft tissue being healthy and stable. But this could also result in a problem later on. Now, this, we were lucky because we had a tooth color abutment underneath, but this is the problem. You see the smile line of the patient. Now, she's been 7 years with the implant, and she says, look, what happened there? And she thinks it's her fault, because she was brushing too high or too, So this is just to tell you that the importance of the surrounding living tissues around the implant is essential for the preservation and maintenance of these peri-implant tissue levels that we have, particularly true in the aesthetic zone. And what is more important here, these changes, they don't happen immediately. They go gradually throughout time. So that's why it's important that we have a long-term follow-up. So I'm going to show you now a different study that we measure the soft tissue changes around the implants, but in this case, all these implants are in a conventional fashion, meaning they were placed when the site were healed, or they were grafted at the same time with that early placement approach with the simultaneous grafting. So what we did is we measured, this is after implant healing. You can see there is no morphology of the peri-implant soft tissue here. We handled that with a provisional restoration, and then we finalized the prosthetic outcome. And we measured that at the baseline, at crown insertion, 1 and 2 years follow-up. So you can see here that when you have enough surrounding tissue, particularly peri-implant bone around these implants in the aesthetic maxilla, you have pretty much the width of the keratinized mucosa, and all these parameters, they remain stable throughout time. So it looks like this is a very particularly important component to have the peri-implant stability. We are measuring now when you do cases flapless. We even see that it's more important because there's no disruption of the periodontium. Not all the cases could be done flapless, but in those cases, they work really nice. Then we measure the DIM, and this is something that you will be interested in because it's the distance from the implant shoulder to the marginal mucosa, and see how that changed from one position to the other. And I can show you here, the blue line is the measurement before inserting the crown at the buccal aspect, mesial, lingual, and distal aspect. And you can see the red one is at the crown insertion. And the buccal aspect, because we always like to keep the tissue more coronal than we need, it went a little bit apically and remained stable at 1 and 2 year follow-up. But look what happened at the mesial papilla. Before inserting the crown, 3.2 millimeters. As soon as we insert the crown, goes to 4.5, over 5 millimeters at 1 year, and remain at the same level 2 years after. So that means that the way your prosthesis interact with this peri-implant soft tissue has an impact in the shape, morphology, and architecture of that transition zone or emergence profile, or the configuration of the peri-implant soft tissue. And that calls for a high level of customization. And I'm going to show you the next slide here. These are 8 cases of this study from the occlusal view. Just so you see that I'm not showing you just the case that went right. I'm showing you all of them. And if I make abstraction of the color and I show you the outline of this emergence profile, it looks, each case is completely different. So you can't really say, oh, I'm going to use the same component or the same part for every case. It has to have some degree of customization, whether you go cement or screw retain. The same from the buccal aspect. You see the same 8 cases here. And if we make abstraction of the color, you will see this is even more demanding here. Some of them are in a semi-lunar way. Some of them are more rounded. Some of them are more squarey. But this is kind of the way you handle this emergence profile. And this is done for the prosthesis. I submitted a paper on this technique, and there are many others that they have been done in the same way, to a prosthodontic journal. And they say, what this soft tissue implant has to do with the prosthodontic journal. That was the review, their answer from the editor. And I just said, everything. everything is done with the prosthesis. And I don't see how you can achieve that. Yes, you can customize a custom abutment, but ultimately, this is maintained and supported by the prosthesis. You can go 5 years down the road. You take the prosthesis down, the soft tissue will collapse in 2 seconds. This is how important it is. So then you see the soft tissue, they have to be, in my opinion, when you achieve this level of configuration, clinically, they have to be transferred to the lab technician accurately, so they can do a crown that has the same outline as the one you have. And we are now using this intraoral impression, which I think they're perfect for that. You see, we just took the provisional out, we put the scan body, we scan the area, and you will see now on the video very quickly when we mark the outline of this presentation, how the emergence profile was accurately captured in this way. And before that, if you heard me speaking about the same topic some years ago, I would have said, well, you need to put your impression copy, do your acrylic customization, then pick it up, or indirectly make it in the model. Now I think it's not necessary. This digital technology will quickly capture that. We're going to take now the abutment, and you can see there, and I'm going to flip a little bit the model so you can see the accuracy of reproducing this emergence profile. Because the problem of this emergence profile with conventional impression was the pressure from the silicone material, made it collapse it. You know, so the digital impression is a non-contact impression, so therefore you can capture it accurately. Now, you have to do it quick. If you wait 10 minutes, this will collapse on its own, but if you do it quickly after removing the provisional, you can have a very nice reproduction of your emergent profile digitally. Now, the advantage of that is that you go with one email, you go to your dental technician, and the dental technician will, with the same file that we just produced, start making your abutment, your prosthesis, or your elements. And I'm going to show you here. This video lasts only 1 minute. You can see we are making an abutment for a cemented restoration here. But the whole fabrication of any of these CAD/CAM systems, this is not particularly this one, any one that you use, within 2-3 minutes, you will have the design of your abutment ready. And then, of course, you can do all the modifications, send it out until you can get your abutment like this. You see, now I have followed completely the emergence profile that I showed you in the presentation. I know that my margins are slightly subgingival for the removal of the cement, and at the same time, I have supported all that structure with the custom abutment. This is particularly important in the aesthetic area. Now I'll show you another case a little bit more challenging in handling the soft tissue. These partially dentulous patients with the extended dentulous gaps are always very difficult to do, and not always you can achieve the same level of the scalloping in the anterior maxilla, but probably this is the most that I've seen in a case. That's obviously why I put it in the presentation. But there will always be a deficit between where the natural papillary levels should be in relation to the mucosa in these cases. So that's why we like to interact with the prosthodontic work, and I will show you a trick here. You need to, again, pay attention with your eyes. If you see at the embrasures, these embrasures are slightly more saturated than they should be in terms of the ceramic veneering. Patients normally don't like that. They say, oh, you know, my teeth, they look a little bit brown in between. But when you put the lip back, you see what this does. This creates an illusion that some sort of a tip of a papilla is coming down. You know, if you do not perform this interproximal staining, in my opinion, what you will get in there is the piano keyboard effect, right? Where all the teeth, they look white in the surface and they look white in depth, you know, and depending on the light reflection, it's what it looks sometimes that is not so natural. You see, this is a very minimal. I'm showing you a 1:1 ratio here. This is a very high magnification, and this patient had already a very, a high value on the or high number on the shading on this area. And you can see the levels here. This is where the papilla should be. This is where the interincisal papilla should be if the case was anatomically correct, but you will never get it down there, right? So that's why it's a small prosthetic trick that you will go that you can use that. We have also measured that in the edentulous patient. I'm going to briefly show you that. Here it's a little bit challenging. You see, we measure whether this scalloping that you use in a fully edentulous patient can really get this interproximal papilla, which is nothing else than the edentulous mucosa, as you can see here. And then what we determined with this study is that when we measure these almost 100 implants in question, is that the most coronal part of the papilla-like mucosa at the interproximal sites will be the nearest of the original mucosal level before treatment. In other words, you're just scalping into the thickness of the edentulous mucosa. If there is no tooth structure, you cannot have an interproximal papilla. So you can only work within the thickness of the edentulous mucosa, and that has to be planned, because if you have a patient with a very thin mucosa, an edentulous patient, you may not have that room. And then you will need to move on into a pink prosthetic design, as I will show you in a moment as well. So all this, we measure this for you. I mean, when we do research at the university, we have time and we have a lot of help from residents, but I was always trying to focus my research oriented to the clinician out there who needs answer. I was one of myself when I early finished dental school. I was in my office and it was difficult to find answers. Science was too complicated. When I was reading those papers, I didn't understand half of the things they were saying. So I'm focusing my research into answering clinical questions that we can all agree or disagree, but at the end you can get a clear message what you can take home. And this is a closer view. These are the two implants placed, and here you have the small scalloping. And this is true for the partial edentulous patient. Now, where is the clinical relevance here? Well, if you're going for a conventional approach, I think it's important that your implant connection, implant prosthodontic connection, is deep enough to allow that connection to happen within the thickness of the edentulous mucosa. Otherwise, you will have a flat interface between your soft tissue and your prosthesis. That's simple. If your connection is not at least 1 or 2 millimeters into the thickness of the mucosa, then you will have no way of scalloping this soft tissue. And you will see now when I show you in a moment some of the clinical cases where is the implication of that. Now, of course, most of the time, this will call for a screw retain because of the deep connection that you have. You see here one of the cases. I'm not going to address the number of implants and the distribution. That's a topic on its own. But you can see here, this is the maximum that you will see on an edentulous patient. And if your implants, you see these are 2 implants, and the implants were placed at different levels, you will also have a different level in your soft tissue there. So, and nowadays you can really prepare all that information in advance. Now, let's move on to the prosthetic part. So I have shared with you the implant position, the importance of the maintenance of the surrounding living tissues. I have shared with you how to handle the soft tissue. I would like to share with you now some prosthodontic consideration. Now, by now you all know where the implant is in here. That's not difficult to find. But what I'm saying is, oftentimes we send a prescription to the dental technician and we say, please fabricate an implant crown A2, A3. And I just wonder how a dental technician with such a complexity in the anatomy here can fabricate a crown when you say just, or when we say A2, A3. So for me, it's impossible. I don't know if we have any dental technicians in the room. Raise your hand so we can see. Do you agree with me or not? Thank you. At least we are two that were thinking the same way. But this is the truth. I mean, nowadays, I don't mind if you use your cell phone or your professional camera, but at least a picture should be sent so this implant crown can have some small characterization to mimic what the patients have. Otherwise, an implant beautifully placed, the soft tissue is beautifully managed, they will not look right. Because we do not place implants, we do not handle the soft tissue just for the sake of doing it. We do all that to restore a missing tooth. So this is the most important part of the complex. Of course, I'm a prosthodontist, and I have to say that. But the implant, ideally, should not be noticeable. The soft tissue should look natural. But this is the only thing, your prosthetic work, that we cannot hide. And therefore, where your attention should be the highest. So that's why we ran this other study. It was published in 2011. We wanted to see first if the material had an impact. I'm going to now address the question whether the all ceramic components and crowns had a difference with the traditional conventional PFM crowns. I show you here, these are all the cases. We did a significant amount of measurements, and you can see that not all of these are perfectly or ideal. But let's do a test. For example, if I say that this is a PFM crown, and you agree, please raise your hand. So it doesn't matter, you just say yes or not. Sure, I have only 10%, but let's move on. How about this one? Where is it now? If I say this is one, it's an all ceramic crown. 23.29%. That is a little bit much better. Now, then this is what we did on this test. Besides measuring all the objective parameters, we asked the clinicians, can you really see the difference? And these patients, they were randomized in a way that the patient was assigned to a group, but we didn't know what crown we will be delivering these patients until we took final impressions and we opened the randomization envelope. So we could not really assign the patient to one side or the other. And I show you now, these are all the PFM crowns, and these are all the all ceramic crowns. And basically what the statistician says is that the clinician's accuracy score, there were 47% for the PFM positive responses and 50% for the ceramic. It was just a random guessing. So if you use any technique and your dental technician is doing a good job, you can achieve aesthetic results, either technique. The reason why I'm saying this is because often we fall under the impression that, oh, because I use all ceramic, it will look nicer. And that's not true, dear colleagues. You know, you still need to have, and I can tell you, if you use a very dense zirconia monolithic crown in the anterior area, you will have a much harder time than a traditional PFM. You know? So material per se will not change the aesthetic outcome, but yes, will do the way you interact with the dental technician. Then we measure the patients. I show you here, no difference. They all like about 90% the crowns that we gave them, and 2 years after, they were equally happy with the PFM or the all ceramic crowns. Then we did a more objective evaluation, which is the pink and white aesthetic score with a maximum of 20. We got a 14, almost 15 for these crowns. But what I want to point it out here is that the lowest scores that we had, tooth volume and outline, and translucency and characterization. Again, those are prosthodontic parameters. And those who work in highly demanding aesthetic cases, they will know that getting the color is not a problem, but the tooth volume and the translucency and characterization of that restoration are the most challenging aspects of this aesthetic restoration. I show you here probably the nicest case I have. And you can see 3 crowns. This is a lateral incisor, natural, and this is the contralateral crown with 2 crowns in the central incisors. And I cannot tell you how much effort we put in matching that. It's obviously a very challenging case, but it all comes, in my opinion, to the prosthetic work, the way you interact with the dental technician. Now, if you ask me, if you say, I work only with one dental technician, I think that in the same way we clinicians have the surgical team and the prosthodontics team, dental technicians are also specialized in anterior cases and in posterior cases. And you will see a difference in those cases. A technician that it doesn't have the skills or the preparation to do the aesthetic cases may not achieve the same result, or vice versa. My anterior cases dental technician is not as good in molars as my posterior technician is, you know. But that's the truth. That's the way it works. That's why the patient goes to the periodontist or go to the prosthodontist. It's a professional predisposition to do the work in certain areas. But for you, with this important, I'm going to share just basics, principles of this prosthodontics, is the transition lines. You see here these marks, they will determine the character of the crown. These transition lines, it doesn't really matter that your crown is wider or shorter. What it matters is these transition lines, they follow the pattern of the adjacent teeth. In other words, if you made them parallel, your crown will look like a square tooth. If you tilt it a little bit towards the apex, your tooth will look triangular. If you give them a certain curvature, your tooth would look like an ovoid shape. This is how important these lines are. And this is what we call the outline. This is what the eye sees. This crown is 0.3 or 0.4 millimeters wider than the other one, but you don't see it because the transition lines are placed at the same distance from each other, mimicking the contralateral tooth. Second, but not least important, is the surface texture. I know the group of the Salama and the Gervers and the Atlanta team have published extensively on that. But you see, the way you interact with this surface texture is very important. We apply this golden powder. This is the natural tooth, and this is what the crown looks before treating the surface. And what you see here is that the 2 light reflection on the crowns, they look completely different, right? Because the light reflection that you have in there. So the good news is just with a small anatomical work of that surface, you can make the implant crown look exactly the same like the natural tooth, and now have the light transmission through the specifics of the material and the light reflection through the specifics of the surface texture in there. And this is the final case. I always say the same. I wasn't really happy with this bump here, but the patient says, you know what, you don't touch my tooth anymore. I'm happy like that. And I didn't have an extra chance. But no, it's good integrated. You see here translucency and mimicking all these aspects for this patient. You can see here, this is the patient at the follow-up. So I move on to a different case. Now these cases are a little bit more complicated because you have a combination of implants and natural teeth, and this is, in my opinion, a very challenging case. So what we did here is we took impressions, then we used the digital technology, we copy out the shape of the veneer preparation to make now a veneer abutment. So basically we mirror flip that preparation by cutting on the other side. And now I have a custom abutment that looks like a veneer preparation. You can see here, that's what I was saying. If you try to do something on this material with this color, you will be really in trouble there. So we went back, we measured the shade, we stained, and now we have a titanium-based abutment in which this veneer zirconia, this zirconia abutment with a replica of the veneer preparation on the other side are adhesively connected to the titanium base. I put it back in, we stain it, of course. Now the 2 underlying structures, they look alike. You see here this custom abutment, not only customization of the emergence profile, but the preparation of the veneer. And then we cemented 2 veneers, one on the tooth and one on the implants to show you the case. And this is the final outcome. This is a baseline. So this is an implant, this is a veneer, but now I know that these 2 veneers will look the same because I prepared the underlying structure in the same way. And I show you here, this is the picture clinically. You can see here the 2 veneers, one on the implant, one on the tooth, and now this is 1-year follow-up. And this doesn't take much work or extra work than making an abutment. So what we will see, dear colleagues, is not only the type or the design, but we will start seeing a lot of this adhesive restoration in the aesthetic area, because for the dental technician, it's easy to work with the same thickness and same underlying structure with the same color to achieve the aesthetic outcome. Now moving on, I show you another large cases. Here is a little bit more complex, but you see again the same principle, handling the surface texture and the morphology, as you can see here, with a compensation with pink ceramics. And here the trick is that you need to work on the dental, on the white portion on the surface, completely different than you do it on the gingival part. And you can see here we're giving a little bit of horizontal texture to reduce the height of this complex, to make it look a little bit more shorter than in fact they are. And you can see here the final prosthetic work. I like this picture very much because you can appreciate how the surface texture was worked on the teeth and how differently was addressed in the ceramic. Oftentimes I see this pink ceramic polished and flat, and this is probably one of the simplest things to address to improve the aesthetics, is not making this flat and polished, because the soft tissues are not like that. And then your light reflection will be completely different. This is the case intraorally. We try to hide this transition line always to the lip line, but again, we think, again, the integration on this patient was interesting. Now, of course, we can question a little bit the shape and the superimposition, but that's something that we tested with provisional, and the patient was obviously happy with that. Now, I have shown you a certain array of cases, and in the last 2 minutes I have left, I want to give you a practical way that you can measure your aesthetic outcomes at home, in the practice. But you have to be honest. So, the first, what I show you here, this graphic, is very simple. Every of these single dots that you see here represents the intersection of the patient assessing your aesthetic outcome and the clinician assessing your aesthetic outcome. So you can see here on this axis is the patient giving you a score, and in this axis is yourself giving you a score. And this is we do it professionally, but you can do the same in your practice. You ask your patient, how do you like your crown? Before cementation, of course, or before delivery, because then the question is irrelevant if you do that. And you will see how you say. And you can ask your colleague or your peer or yourself. And then you say, well, if the patient gives you a 5 or less, or you give yourself a 5 or less, that work should not be delivered. At any circumstances, you need to go back and look what went wrong and try to modify it and work out in that way. If the patient gives you between 5 and 8, and you give yourself between 5 and 6, you will be in what we call the standard deviation. And probably these are the 2 cases that we did wrong. We shouldn't have delivered those because the value was too close. But these 2 are really interesting. This one, for example, the clinician gave a good score and the patient gave a low score. Oftentimes in those cases you have something going on. Probably the crown was too expensive, or the patient didn't like the way they were treated, and there's a patient perception that is making the case not to look nice, but in reality it's an unhappy patient because you assess that crown to be acceptable. Now these are the difficult ones, because the patient gave you a 9 but you gave yourself a 6. And oftentimes you will be tempted to look around and see that there is nobody in the office, and you will say, yes, let's cement it. Right? Well, don't do that, because that patient will come back in a week and they will tell you, you know what, I was wrong. And you will say, oh, but you told me that it was right. And the patient will say, yes, but I'm not the dentist. You know? And that's when you professionally need to tell the patient, I know you like it, I have found some things that we need to improve, I'm going to send it back to the lab, make those changes, and then give it back to you. The patient will really understand that. The good news is that if the patient gives you an 8 or more, or if you give yourself a 6 or more, you will be in the green zone. And you will see most of these cases, they are in the green zone. And this is not difficult to achieve. And what you see here is that these 2 cases that they're here on the top are the ones that we normally put in the presentations. So this is the reality. That being said, dear colleagues, I want to show you the last conclusions, and I will say that we need to include all these 4 parameters: implant, soft tissue, prosthetic, and patient satisfaction. And the moment we start addressing the implant prosthetic as a whole, we will certainly improve our aesthetic outcomes, knowing that we need to treat the patient and not to place an implant. These are the colleagues. I'm running out of time, and I'm sorry that I went a minute over. Thank you very much for your kind attention.